Two contrasting events during labor and delivery are shoulder dystocia and precipitous delivery. Both can lead to perinatal and maternal complications. The anterior fetal shoulder can become wedged behind the symphysis pubis and fail to deliver using normally exerted downward traction and maternal pushing. This condition is known as shoulder dystocia. Shoulder dystocia is the inability of the fetal shoulder to deliver spontaneously or with gentle traction. Thus, it requires certain maneuvers. The impaction of the anterior shoulder on the symphysis pubis may be a result of an impaction of the posterior shoulder to the sacral promontory. This is not a soft tissue problem. Prior to labor, risk factors of shoulder dystocia include fetal macrosomia, maternal diabetes, gestational age more than 42 completed weeks, multiparity, previous history of shoulder dystocia, previous delivery of a macrosomic infant, excessive weight gain, and extreme maternal obesity. During labor, risk factors include prolonged labor, operative vaginal delivery, labor induction, and epidural anesthesia. Consensus regarding a specific definition of shoulder dystocia is lacking. Some focus on whether maneuvers to free the shoulders are needed, while others use the head-to-body delivery time interval of more than 60 seconds to define shoulder dystocia. Currently, the diagnosis continues to rely on the clinical perception that the normal downward traction needed for fetal shoulder delivery is ineffective. It is usually recognized when the head recoils against the perineum, also known as the turtle sign, and spontaneous restitution does not occur. Because shoulder dystocia cannot be accurately predicted, general management principles involves avoiding the four P's. Avoid panic, pulling, pushing, pivoting. Shoulder dystocia drill is recommended to better organize emergency management. First, call for help. Mobilize assistants, including the pediatrician and anesthesiologist. Empty the bladder. Do a generous episiotomy. The suprapubic pressure is used initially because it has the advantage of simplicity, and only one assistant is needed to provide suprapubic pressure while normal downward traction is applied to the fetal head. The macroverse maneuver requires two assistants to grasp each other's leg and sharply flexes the maternal thighs against the abdomen. In most cases, the first two maneuvers will resolve the shoulder dystocia. If not, the following maneuvers can be done: delivery of the posterior arm, wood screw maneuver, and Rubin maneuver. Other techniques are reserved when all other maneuvers fail. These include intentional fracture of the clavicle, Gaskin maneuver, and Savanelli maneuver. Anterior disinfarction is done by moderate suprapubic pressure applied by an assistant in a CPR-type motion and directed by the side of the fetal back, while downward traction is applied to the fetal head. No maternal pushing until shoulder is disimpacted, and fundal pressure is never done. Pressure is applied with the heel of the hand to the anterior shoulder wedged above and behind the symphysis. The McRoberts maneuver is often selected next if additional steps are needed. The maneuver consists of removing the legs from the stirrups and sharply flexing them toward the abdomen. Suprapubic pressure is often concurrently applied. The next step is manual removal of the posterior arm. The operator's hand is introduced into the vagina along the fetal posterior humerus. The arm is splinted and swept across the chest, keeping the arm flexed at the elbow. The fetal hand is grasped and the arm extended along the side of the face. The posterior arm is then delivered from the vagina. Wood's maneuver involves progressively rotating the posterior shoulder 180 degrees in a corkscrew fashion. The hand is placed behind the posterior shoulder of the fetus. The shoulder is then rotated progressively 180 degrees in a corkscrew manner so that the impacted anterior shoulder is released. First, the fetal shoulders are rocked from side to side by applying force to the maternal abdomen. If this is not successful, the pelvic hand reaches the most easily accessible fetal shoulder, which is then pushed towards the anterior surface of the chest. This maneuver most often abducts both shoulders, which in turn produces a smaller bisacromial diameter. This permits displacement of the anterior shoulder from behind the symphysis pubis. The Gaskin maneuver is also known as the all-fours maneuver. The parturient rolls onto her knees and head. Here, downward traction against the head and neck attempts to free the posterior shoulder. Deliberate fracture of the anterior clavicle using the thumb pressed towards and against the pubic ramus can be attempted to free the shoulder impaction. In practice, this is very difficult, but if successful, the fracture will heal rapidly and is usually trivial compared with brachial nerve injury, asphyxia, or death. Zavanelli maneuver involves replacement of the fetal head into the pelvis, followed by cesarean delivery. Terbutaline is given to relax the uterus. The first part of the maneuver consists of returning the head to an occiput anterior or occiput posterior position. The operator flexes the head and slowly pushes it back into the vagina. Cesarean delivery is then performed. The alarmer is the mnemonic used to help one remember the following procedure and maneuvers. A. Ask for help. L. Lift the buttocks and the legs. A. Anterior disimpaction. R. Rotate the posterior shoulder. M. Manual removal of the posterior arm. E. Episiotomy. R. Roll over onto all fours. Labor can be too slow, but it can also be abnormally rapid. Precipitous labor and delivery is extremely rapid labor and delivery. It may result from an abnormally low resistance of the soft parts of the birth canal, from abnormally strong uterine and abdominal contraction, or rarely from the absence of painful sensations and thus lack of awareness of vigorous labor. Vigorous uterine contractions combined with a long, firm cervix and a non-compliant birth canal, may lead to uterine rupture or extensive laceration of the cervix, vagina, vulva, or perineum. It is in these circumstances that fluid embolism most likely develops. Precipitous labor is usually followed by uterine atony. The uterus that contracts with unusual vigor usually is likely to be hypotonic after delivery. For the neonate, adverse perinatal outcomes from rapid labor is increased considerably. The tumultuous uterine contractions, often with negligible intervals of relaxation, prevents appropriate uterine blood flow and fetal oxygenation. Herb or Duchenne brachial plexus is also associated with precipitous labor and delivery. Finally, during an unattended birth, the newborn may fall to the floor and be injured, or it may need resuscitation that is not immediately available.